Oh, no, she's back there.
She's talking to other people.
Yes. Bags.
I miss my calling as Oprah Winfrey. So this is the
Good.
next
This
best
is
thing.
this is Oprah Winfrey.
Yeah.
Whatever you would like to be. I'm going to get us started. Can you hear me?
Is that Judith?
Hi, Judette. Can you hear us? So you're sitting up here, right?
So apparently I'm sitting up here now, yeah.
Perfect. Perfect. Well,
Where would you like to be?
I'll be on the edge. So how do I get the mic to? Oh, you're going to turn it on? Are we ready? Can you hear me? Okay, great. Judette, can you hear us? Oh, but we can't
We can't hear you.
we can't hear Judette yet.
He's working on it.
Okay. Oh, you understand the signals. Very good. Thank you all. I'm sorry we're a few minutes late. My name's Janet Kadoff. It's lovely to see you with us in our breakout session focused on disparities and inequities in women's health. I'd love to get started by having each of actually my friends and collaborators introduce themselves. Maybe we'll start with Judette because I don't want you to feel I want you to feel really a part of our panel here, Judette. So why don't we start with you? If you might introduce yourself and just briefly highlight sort of what are the most important questions, what are the most pressing aspects in your work or in your experience or in your thinking about these issues around disparities in women's health.
All right, can you hear me now?
Yes.
Oh, awesome. So my name is Judette Louis, and I am by training a maternal fetal medicine physician. So I practice high-risk obstetrics. I am currently the department chair for OBGYN at University of South Florida in Tampa, Florida. Day to day in what I do, I have to admit that disparities in health inequities was not necessarily something that was at the forefront of my mind. But as you continue to practice and as you continue to conduct research, you can't study morbidity without noticing that there is a difference. And then once you notice the difference, trying to figure out what you can do about it. And so that distinctly led my research into the realm of health inequity. And where I think we are now, is that we've made a tremendous rate of growth within recent years in acknowledging that we need more attention to health inequities, but in particular that we need to stop studying that the fact that there is a difference, but rather quantifying the difference, where those differences are, and more importantly, the interventions to be able to make progress in reducing disparities in outcomes and the inequities that we see. The most prominent example that I found, I wanted to reduce the number of women who receive blood transfusions because of obstetric hemorrhage. And so we studied within our system, and sure enough, there was a difference. If you were Black, you were more likely to end up with a blood transfusion. But when we looked at the predictors of that, we found that our management was exactly the same regardless of race. But the difference was that Black women were coming into their labor and delivery experience with more anemia. And so when you start diving into why that is, it's because we needed to treat them as an outpatient. And so that our intervention would have to be as an outpatient, right? We would take the intervention out of the hospital and into the clinics, reducing the bias of people thinking, oh, it's okay to be anemic because you're Black and we just expect that, but rather doing something about it. And so that's just one example where if we're asking the right questions, only then can we embark upon the right interventions so that patients can do better. And I'll stop there.
Thanks, Judette.
Hi, everyone. I'm Jada Sherrill. I'm the Chief Executive Officer of Healthy Start in Pittsburgh. I'm also a past participant in the Healthy Start program. So I have 3 boys, a 19-year-old, which is the child I had when I was in the Healthy Start program, one in the middle who's 13, and then one that I had in the last year who just turned 1. So they're all over the place. But I'm really excited to be here and to talk about our work at Healthy Start, which spans the space of delivering community-based interventions and supporting women in our community and babies with a focus on Black women, as well as our really, really strong and heavy focus on collaborations, research, and policy and systems change. And so I'm really happy that all of the panelists here are actually partners and friends of Healthy Start. So it's really important work. And when I came into this role 5 years ago, I didn't really know that we would be doing so much in the space of like research, advocacy, and systems change. But it's an essential and core part of our work. It's essential to understand what goes on in the clinical spaces, as was mentioned around. And I always think about kind of my own experiences when, I hear about kind of the clinical implications. So, as a Black woman who is anemic and was told I was anemic while I was pregnant and given iron pills, but it was never explained what the outcome could be if I didn't feel like taking those iron pills. So just thinking about kind of like how these things really play out in real life and how they play out for the women that we serve, who, many of the women that we serve in the program don't necessarily have the level of education that I have, or nor do they go into the doctor's office with the level of advocacy that I naturally have and with the work that I do. So our goal is to really translate, to be a partner in translating what goes on in the clinical space to community, so that our moms can have better outcomes and so that we can be contributing to the science as well. And realizing that our work goes beyond just the perinatal period and that we have to be focused on women's health more holistically because, like you said, when we have to be concerned with the health of the mom, of the woman when she goes into, when she may make the decision to become pregnant, or even if she doesn't, we need to be concerned and invested in women's health through policy, through our interventions. And then the interconception period is really important in the work that we do because a lot of the women that we serve, they have multiple pregnancies and multiple births. And so when we look at things like Medicaid coverage and advocating for Medicaid expansion covering women beyond 60 days, when we deal with, again, Black women who do have higher rates of chronic health conditions, what happens to that woman if she doesn't have the insurance and ability and access to manage her chronic health conditions between births? What will her birth outcomes be like? We don't want to be starting at square one with every mom with her next pregnancy. So glad to be here and looking forward to continuing this discussion.
Hi, everyone. My name is Jewel Scott. I am a nurse and a nurse practitioner. I worked in federally qualified health centers for most of my career, both in Chicago and rural North Carolina. And now I'm partnering with one of the FQHCs here in Pittsburgh, as well as with Healthy Start. What brought me to Pittsburgh is actually my research. I finished my PhD just recently, and I study young adult women, Black women, and the development of cardiovascular disease. And a lot of that comes out of my clinical practice of seeing really difficult to control blood pressure, really early onset of cardiovascular disease risk factors. And not all of these women had the traditional risk factors. And so a lot of conversations with women and really interested in this intersection of social context. I think we've done a lot of study of health behaviors, and we know those risk factors, but thinking about all the other things that intersect with that and that may make it challenging to really achieve some of the standards that we know that we need for people to have optimal health. And so my research really takes a look at cardiovascular disease in young women. How do we prevent it? What are some of the things that are happening developmentally at that stage? And so that's kind of how I intersect with the pregnancy and the postpartum space, thinking about how do we recover health after a woman has a baby. If she had a complication during that pregnancy, we know there's risk to her health long term with that. And so this is really a critical time when we can do some interventions. In particular, I'm getting very interested in thinking about that intersection of mental health as well, I think postpartum depression, we think about it in that very narrow 4 to 6 weeks. They do their Edinburgh and we send them on their way. And we know that there's a good probably third of women who postpartum depression does not remit in those first 6 to 12 weeks and last a year and even longer. And so what should we be doing about that, and how does that impact her health? And so that's kind of a little bit about the research that I do and kind of what informs that research, and look forward to this conversation and glad to be on this panel with these amazing people. Yeah.
Awesome. Thanks, Jewel. Liz?
Awesome. Good evening or good late afternoon to all of you. Thank you so much for inviting me, actually, Janet, to be part of this panel discussion. It really is an amazing joy to be with my esteemed colleagues. And I am the Director of Adolescent and Young Adult Health at Children's Hospital, and also have the privilege of guiding community engagement for clinical and translational research at the University of Pittsburgh. And so I think I'm on this panel to talk about two things. One, adolescents and young adults, and bringing a developmental lens into how we think about women's health and women's health equity. And for myself, just by way of background, I have a doctorate in anthropology, which I did while I was going through medical school. And the PhD in anthropology in the early 90s actually introduced me to Black women scholarship and Black feminism, and to Audre Lorde, Bell Hooks, and many, many other scholars. And so was doing my research on violence against women and girls and the trafficking of girls from Southeast Asia into Japan's sex industry. And the fundamental sort of ways in which we think about syndemics, the ways in which we think about intersectionality, and the vital importance of community voice in the work that we do comes from the amazing Black scholars whom I had the privilege of learning from. And it is that reproductive justice frame that I think is one that I would love for us to sort of ponder together. And in particular, in the adolescent world, we have been advocating for a shift from teen pregnancy prevention to one that is much more focused on healthy sexual development and healthy relationship development, and the critical importance of laying a foundation that does not assume that every adolescent wants to prevent pregnancy, and to really recognize the white supremacy that is embedded in the ways in which we determine which young person deserves to be a parent and which one does not. And so, just wanted to put some of that reproductive justice piece and the adolescent piece into our discussion as well.
Thank you. Dr. Issa Davis was also to be on our panel, but she's actually a bit imprisoned in study section and not yet done. So if she's released, she may appear on our screen. But we have a great panel of folks. I have questions that I can kind of get us started, but I'm really hoping that this will be a genuine kind of discussion. And so I would encourage, if I can't see who might be logging in virtually, but we see your questions on the screen here, and actually Jewel's going to be monitoring the chat. So any folks that are attending virtually, please send questions via the chat. I'll get us started, but please come to the mic, ask your questions. I'm really hoping, one of the feedbacks from our first summit was, gosh, there needed to be more time for discussion. So I'm hoping that maybe we can achieve some of that here. I was going to get us started. We've got some of the themes that were raised earlier today for folks who didn't have a chance to be here were there was a lot of enthusiasm about thinking about pregnancy in a more life course, lifespan approach. And I wonder what, Liz, I'm thinking as an adolescent medicine expert, like we have a lot of questions about the preconception. You talked in this reproductive justice framework, and I love that. I'm inspired by that. I just wonder for each of you what we think about the how, the when to engage women If we're thinking, and I'm sure I'm not using the right words, I have so much to learn, but if we think about pregnancy, then we think about what comes before pregnancy as preconception, but it really is developmental. So maybe Liz, will start with you, but I'd love to hear from everyone about this idea of not only how we study, but how we engage and ultimately improve the health of women, sort of even before they are at a first prenatal visit. So Liz, maybe we'll start with you.
Yeah, no, absolutely. Thank you. Because I, love talking about how we might be able to actually fundamentally change the ways in which we think about women's health across the lifespan by starting with comprehensive sexual health education. And, from kindergarten onwards, what does comprehensive sexual health education look like that also honors reproductive choices? And I think what has really shifted for us in adolescent medicine as we have pushed against this sense of all we're here to do is prevent pregnancy, but much more to say, how do we support you with your life goals, and where does pregnancy and parenting fit into those life goals? How do we help you get there? And that is a very different kind of conversation. But I think part of that comes with a critical need for us to talk about healthy relationships and healthy, positive, pleasurable sexuality as a vital piece of adolescent development that has really been missed in much of our pregnancy prevention work, much less preconception counseling, right? And to have a young person who's like, I don't know, Dr. Liz, I don't know when I might want to become a parent. And I don't want to really use hormones. I prefer to use condoms as my mode of contraception. Then let's sit with that and think, just in case, if you do become pregnant, it is helpful to have enough folic acid and other nutrients in your diet. Is it okay we talk about that? Could I also give you a prescription for a multivitamin with folic acid at the same time that we're also talking about methods of contraception that may or may not work for you? And being able to have both conversations, that it's not an either or conversation, I think is really one that we're finally in adolescent health getting much more comfortable with.
Great, thank you. Jewel, any thoughts on this question of preconception, adolescent health,
Yeah, I think
reproductive
very
planning?
similar to what Liz mentioned is what I was thinking was that, like, there's really no place. We don't have a framework for preconception health. There's as far as like having a health visit or opening the conversation as clinicians. We just have not done a really good job with that. And I think about the emerging adults, and so they're leaving adolescence where maybe they did come in at least for every year for a well adolescent, well child visit, or came in for immunizations, and they're in that 18 to 24 time period when there's nothing necessarily to engage them with the health system, and we haven't done a good job with sex education, as Liz mentioned, or even figuring out how do we reach that age population. I think, the pandemic has shown us that our public health infrastructure needs some work. And so just always expecting people to come to us. Maybe there's other creative models we need to think about how we engage people and provide that health education, that preconception, so that we ideally have people entering pregnancy as healthy as possible.
So I agree with everything that's been said. I think for me, I think as a society, we kind of operate on these polar ends of the spectrum. Either we're expecting young people not to have sex, and we're, saying how bad it is and why you shouldn't do it, and you certainly shouldn't get pregnant or get anyone pregnant. And then on the other spectrum, we see all of this over-sexualization everywhere. And I think reality is somewhere in the middle, that young people have relationships, they have physical desires, they have, bodies and hormones like the rest of us, and we don't prepare them to deal with that. And so in this space of serving pregnant people, and a lot of times we do serve teens, and they don't even know anatomically what's going on. They don't know that the baby's coming out of their vagina. I mean, this is, this is real. They don't know. Not all of them, but some of them. And so I just think as society, we need to do a better job with being more open about, how we talk about sex and sexual activity as, a natural part of life, and how we equip young people to make, with critical thinking skills, to make decisions, life planning. I think if we focused more so on educating for critical thinking and to have some autonomy, then we would have better outcomes. Speaking of pregnancy, intention, we deal a lot with, we ask questions of our moms, did you plan to get pregnant, things like that, and I think we need to rethink pregnancy intention. Culturally speaking, and I don't know, how it is in other cultures, but I think there's an assumption that if you intended to get pregnant, there's a high value placed on that. You take your folic acid, you go to the doctor, you've planned it, you talk to your partner, whomever. But those who don't intend to get pregnant love their babies just as much, want to have a healthy pregnancy, want their children, want their babies. There's not always this planned discussion where you sit down and say, let's work this plan and have a baby. It happens, So I think that we need to, in our medical space, be thinking about other ways of having that conversation and embedding those resources for those who are not necessarily intending. And just because you didn't intend to get pregnant also doesn't mean you intended not to get pregnant. So I think just really operating in the space of people's reality and not always in these frameworks of evidence and research and medical practice, but what is really going on in people's lives.
Thanks. Judette, I'm going to ask you to weigh in on that, and then also potentially thinking about it from sort of the high-risk obstetrics view, maybe also begin some of the dialogue about the health system and what are some both observations, obstacles, and opportunities to do some of the things we've begun to talk about. But I'd love to hear your thoughts on sort of preconception opportunities as well.
Yeah, I will take it even earlier than adolescence, and in part it could be because my twins just turned 15 today, and I don't want to talk about adolescence and sexuality. But I will take the stance that we have to start earlier. When you look at the data about adverse childhood events and subsequent health of adults, I think there's significant data there to show that the window of susceptibility starts even earlier. And if we're to emphasize the health of these individuals across the lifespan and saying that your worth is beyond the outcome of your pregnancy should you choose to have one, but rather we want healthy individuals. It starts with the adverse childhood events. It starts with the mental health and putting in place resources so that those who need mental health support early in childhood and through the adolescence can have that, because we know it sets them up for how you cope with stress, sets them up with differences in behavior and choices in life, and all of that sort of spirals into if you have a pregnancy, the outcomes of the pregnancy and the PTSD and depression that happens there, and it all just snowballs. So that's my perspective on it. I think we have to start even earlier with placing that value and then changing really our conversation around pregnancy and what's important. So having said that, sometimes it feels, like it's all too much because really you have to change society. And so how do you change society? From the perspective of being someone in academics, in part, it starts for me with saying that we are going to educate our future, healthcare professionals in a different way. So introducing these concepts early, whether it's concepts about adverse childhood events or really emphasizing the importance of mental health support, and whether you're talking about your physicians or nurses, midwives, et cetera, that it has to start with us teaching a different way, teaching about where all the biases, because some of the bias and health inequities you see that the patients experience day to day were taught to individuals within the healthcare system. And so pointing out to them where the information is wrong, where the attitudes are wrong, and what's the right way to approach it. And so from my perspective, that's where, where at least some of us can make a difference, because it just seems so overwhelming to think that you can, you as an individual can rehab the whole system.
I appreciate that, and I'd love to hear from our other panelists about, you talked about training and, training maybe the next generation of clinicians, and that's really hopeful. I love that, but I wonder the perspective of others. Maybe we'll start with you, Jada, on health system challenges and opportunities.
Okay.
From the community advocate perspective,
Absolutely.
right?
So I'll just reflect on a recent experience. So I did a panel at the Pitt Community Engagement Center in Homewood, and it was a Black maternal health panel. And Dr. Betty Braxter, who's at Shady Side School of Nursing, and Catherine, can't think of her last name right now, who is over the PA program at Pitt UPMC, and then Dr. Amanda Casagrande, who works with you. So very great panel, but one of the things that we kind of dug into in that panel was, medical education. And so I had asked a question about what is being done, same question, what is being done in the space of medical education to help equip our next group of leaders and healers to deal with the diversity of the patients that they will serve. And so they talked about like recording patients and recording I guess like the clinical interactions and giving an opportunity for med students to reflect on how they did in their interactions using the standardized patient. And so I asked, well, what is this standardized patient? I mean, I knew what the answer was going to be. So the standardized patient is, a white person. So thankfully, after the session, I got a call and we started to talk about how can we diversify that aspect of our local medical education and make sure that, there is no standardized patient. Why is there such a thing? First of all, let's call it something different, because that doesn't even make sense. I mean, I don't know. I'm not a doctor, never been to medical school, but is there a standard to like, is person A like person B, like person C, like person D? No. So we are working together to identify some community folks who can be trained to do this standardized patient role so that there is more diversity of opportunity for our medical students to experience different aspects of what a visit would look like. I know that I am involved in doing some work with one of my esteemed colleagues who I love dearly, Dr. Andrew McCormick at Children's, and myself and some other community members and Healthy Start staff are working with medical students to do some anti-racism work within their curriculum. We have led a book club reading Medical Apartheid and done some other discussions. So really kind of taking, what do they call it, like taking bites of the whale or whatever the saying is. Like we're taking small bites of the elephant based on, one person's desire to see this system change. But we have to start small. So like these, I think small wins are meaningful. But we definitely, I mean, one of the challenges though is we have a lot of justice-focused young folks who really want to advocate and really want to see themselves serving patients differently than kind of what they know needs to be changed within the system. But they're also being trained by folks who are problematic. And that creates a clash for them, and they, it's kind of like, well, I know this is wrong. I know that the textbook still says this ridiculousness, but what do I do? Like, where is my agency to do something about it? So those are like the conversations that I'm involved in at the community level.
Thank you. Jewel, any insight about the system?
Yeah, I was sitting here thinking about listening to Jada share that experience and thinking about a conversation I had recently with a patient who she's early in her pregnancy, and I was talking to her about a program that we offer, and she was like, well, I really want to try to stick it out with my primary care provider, but she was just having, they were listening, they were talking, but they weren't listening. And I think just thinking about how we educate healthcare providers about listening and that exchange and that dialogue that happens in the exam room is so critical. And I think sometimes, I don't know, maybe people feel threatened when people have questions or just want to understand why we're doing something. And I realize that, that's not to, discredit you as a physician, but she just wanted to understand. And, she said, well, I'm going to go to my next visit. It's a resident clinic. You see a different person. She's like, I think, I believe I'll have a better experience, and so I said, well, how about I follow up with you afterwards? I just want to make sure that you're getting, the care that you need. And, she was really concerned because she's like, if I'm this early in my pregnancy and not being heard and not being listened to, what's going to happen when it's time for me to deliver? She said, I'm really scared. And so, I put a reminder on my phone because I would not remember, just said, call patient bad evening, put her name. So I called her back and she was like, I'm so glad you called. She's like, it wasn't any better. I saw a different person, and I wanted, this to happen. They told me they couldn't do it, but they couldn't explain why. And they couldn't, they just wouldn't answer my questions. They just told me, no, it couldn't happen. And so I think we really have to think about how we're educating clinicians. There's this power kind of, I'm the physician, I'm the nurse, I'm the midwife, and that because I said so kind of thing, which makes me think about, it reminds me of how I was raised in the South. I grew up in North Carolina, and at the time, your parents very much had a because I said so, I'm the parent kind of thing. You do what I say, and that's not really the mindset that we can bring into the exam room, into clinical care, and expect to have different outcomes. And so I think we really have to think about what's setting that up. How do we break that down and kind of get rid of this barrier, because it's contributing to outcomes. We see it every day when a woman who's well-educated, Black woman has worse health outcomes than a white woman who didn't finish high school. Like, a lot of this is that we're not listening, we're not being heard. And so, this patient was very upset, and, and she had a right to be upset, right, that she wasn't being heard. And so I'm thinking about, even as our nurses, how do we train? How do we do our training different? One thing that we did in my last program was motivational interviewing, and so teaching them how to have conversations that they weren't driving, that the patient is in the driver's seat and they're making the choice, and maybe they choose that they want to work on a health behavior that you really want them to stop smoking, and they say, oh, no, I want to work on this behavior, and realizing people have that autonomy, and just kind of how to have those conversations where we don't have to feel like we're in control. And I think that's just been something that has been kind of pervasive in our healthcare system, and I think those are the two things that I think about, that we can start thinking about how do we do things differently.
Liz.
So many things to say about the system. So much, but I'm also known for stirring some pots. So yes, 2020 finally, and how many Black and brown lives had to be lost in this country before we finally were able to pause and make a commitment within the healthcare delivery system that racism is a public health issue, right? And 2020 presented, and it was really in the wake of George Floyd's murder, that for us within our healthcare delivery system, we finally, at Children's Hospital, had an anti-racism statement over a glass of wine. Y'all can ask me about how hard that was, okay? Because these are systems that are where white supremacy is baked into the system, right? And until we are, as health professionals, able to say the history of racism is now, right? And so Andy McCormick, Jada are doing the unbelievable heroic work of training the next generation of medical students in racism and anti-racism work. The challenge for us is that we're still at this level of provider training and not actually disrupting the systems of care. And so just yesterday, one of my patients who were trying to get to an endocrinologist, right, is an unstably housed young adult, is late to their endocrine visit. And what do you think happened? They were told to reschedule, right? That's the problem, right? We do not create systems that understand that, it's not just access to care, it's about receipt of care. And we do not actually go the extra mile, and that is what health equity looks like. And so, in my mind, I love the provider training that we're doing, but I really am focused on the systems level change, right? To get to a point where when I get a flyer, which was the last week, COVID vaccine flyer for the 5 to 11-year-olds in English, and I said, this is lovely. What languages have we translated this into? Crickets, right? That's systems level change. It should not be every single time Liz Miller going, what languages have we translated this flyer into? It should be automatic. So one of the things that we need to do is, in addition to all of this critical work of getting our professionals to be more trustworthy, we actually need to work on making our healthcare system more trustworthy. And that, to me, is kind of this next really transformative work that's needed.
Thank you. Are you coming? Are you going to come ask a question? Oh, good. Join our conversation and introduce yourself and ask. And
Yes,
please join us.
very short. So my name's Ashley. I'm a second-year medical school student at the University of Pittsburgh. So firstly, thank you guys for being here. This is, really eye-opening, and thank you for the work you're doing. I was wondering if, I think some of you said you have some personal experience with Healthy Start, or Healthy Starts. Is that the name of the program? Yes. And I was just wondering, if you could talk a little bit about how that, how that affected your experiences, and then how you've seen that in turn help others. And then also a second piece of that is, how do you think that we can better support these women, especially young girls, as physicians that don't really have that outside support, as whether that's a caretaker, a partner, or whatever, if they are on their own? What are some ways that we can support them, or resources that we can provide?
Thank you for that question. So my personal experience with Healthy Start, I was, I guess I got pregnant in about January. So I was in my first year of grad school at CMU, was with my long-term boyfriend at the time, got pregnant, decided that I wanted to finish my degree. I didn't want to prolong it and maybe not finish and all of that. So I spent most of the year of 2001 in the halls of Hamburg Hall at the Heinz School, waddling around, finishing my degree. Thankfully, I had a lot of support, a lot of personal support, but my doctor, I had Gateway medical insurance at the time, so I was on Medicaid. Went to the welfare office to get my food stamps and had the caseworker tell me I wasn't eligible when I knew that I was. So I had to tell her, oh, yes, I am, and explain to her why, and she, corrected her mistake. Got my WIC, all of that, took care of all of those needs, and, continued about my business. And one of those providers referred me to Healthy Start. And I had no idea what statistically, I represented as a Black woman, young. I was 23 at the time, who was pregnant. I didn't know that, Dr. Jewel, as you said, I didn't yet have much income because I was a full-time student, but, I had a pretty pretty healthy trajectory in life. Didn't know, though, that I was so much more at risk for negative birth outcomes, for premature birth, and for all of these, medical systems experiences. So I'm just, pregnant, happy-go-lucky, dealing with my day-to-day stuff of, I probably looked like I was about 14 years old at the time, and dealt with some things along the way, but had a very, I can't say that I had anything that I can pinpoint as negative during my pregnancy, but when it came time to deliver, I had to have an emergency cesarean. And so knowing what I know now, I think back to, had I been given more time and opportunity to labor naturally, would I have had to have an emergency cesarean, which then, my subsequent pregnancies, I had a cesarean, which took away my choice. Like this time, I wanted to go to the midwife center. I didn't want to deliver at Magee, quite frankly, due to my middle experience when, I just anyway. But it was what it was. The VBAC didn't end up transpiring. So at that time, 19 years ago, I had no idea that I would be back here in this space. But that experience, gives me the voice that I have in this work to be able to advocate and do the work from a place of experience. And so I tell people that when I go home at night, I go home to the community that I serve. So I'm not an outsider to, I truly represent what Healthy Start is. And it's great, wonderful, rewarding work, but it's also at times triggering because, again, when we're talking about anemia, obesity, social determinants of health, those are all of the things personally that I experience, and they're the things that women in my family, in my community, in my inner circle, like I'm talking about myself, I'm talking about my ancestors when I talk about medical apartheid or Dr. Deirdre Cooper Owen's book. So to see yourself in that work, again, is very rewarding, but it's also very triggering. But again, that just fuels my ability and desire to advocate, to see something different and to see change. And then to quickly, I'm sure there are other folks who want to chime in on addressing how do we support young women who are pregnant. I think the first is with, really being introspective about what some of our personal biases or beliefs may be, and being intentional on not projecting those onto those young ladies, because we don't know what they're dealing with at home, in their community. A lot of the young ladies that we serve, that pregnancy may be a serious point of contention in their household that causes them to have to make some really tough decisions. So I think the best thing that we can do is to listen, to love on them as much as possible, and to try to connect them, to make ourselves aware. So if you find that you're working with this population, then you need to get to understand what resources are out there for them and make those relationships and connections so that you can make warm referrals that really work, that are really going to be that are really going to come through for them. I think, a lot of our young people who, end up in situations that they didn't necessarily plan to be in have been failed a lot. And so we don't want to be part of that, of their failures. So just making sure that you are doing your due diligence and understanding what are the best avenues to help them.
I think the only thing I would add is just, thinking about some of the programs. I wasn't sure if Jada was going to talk about our centering program, but I've had the opportunity in Chicago as well as now in Pittsburgh to work with the centering group model prenatal care. And so I think it's one model of really empowering young people, so that autonomy, this is her body, she understands what's happening, they're doing a lot of their own care themselves. She's checking her blood pressure, she's recording it, she's measuring her fundal height. Maybe the provider's going to measure it again, but she's just really understanding what's happening, and she's connected to a community of support. That circle, the centering circle, I think is just really powerful, because, I've really seen ways where women have connected, it's great they're connected to the provider, they're great that they're connected to you as a physician, but that they have a community of people from their community that they're connected to. And so I think it has potential to be a really transformative way of providing care. as well as thinking there's a lot of literature on doulas as well. And I think as thinking about young women, pregnancy, thinking about what do we do in that postpartum period, because I think a lot of programs and interventions have been really tailored for pregnancy, and then they have the baby and we send them home with, very little support to try to figure out how do they, make this adjustment that even people with the, most well-resourced people have struggles during that time. And so I think really thinking about creatively and critically about what are the interventions that are needed in that space. And I know people on this panel are doing some of that work too.
Liz,
one of the things, and Ashley is one of our wonderful future health professionals, right? One of the things that we don't do well in health professional training across the board, but certainly in medical school, is becoming really comfortable with asset mapping, right? So how do we actually, as clinicians in community, learn about these incredible gems, right? For me to be able to, reach out to Jada and say, I have a young person who needs to get connected to a doula, to Healthy Start, to centering, right? But, and often I will have learners say, well, how do you know all that? And I'm like, because that's my obligation, right? It's not extra. It is not something that we then go, oh, that's for the social worker to deal with. We're part of a community. And until we're able to have, as part of our anti-racist work, understand that identifying community assets and building a network of connection and building community around our patients, that to me is where we start to make some really amazing change.
thanks. Judette, what about anything to add to this discussion to help Ashley, our second year med student?
Yes, just one piece of advice is to always ask why, and don't assume you know the answer. And I think that's the best way to support these patients, because if you ask why, then you will understand, or at least get the patient's perspective on the reasons for various questions, various behaviors, and that's one of the best ways to then figure out the best way to approach supporting them.
Judy.
So, hi, Judy Yanowitz. I'm at Magee. So I want to bring up the dirty little word called politics, and I'm curious to get all of your insights into long-term systemic change that could be legislated and improve the disparities in this country.
Okay, who wants to go first?
I'll just start with the Black Maternal Health Momnibus Act. Has everything that you need all in one nice little package that our wonderful, legislators have put together to address from clinical to community-based, all-encompassing. And so we've been focused on creating more awareness and support and education around that act. And of course, paid family leave is really important. We work with women who have to have a baby and I'm exaggerating, but go to work the next day. I mean, it might as well be just that bad. And then of course the Medicaid expansion is critical. So there's the politics, but then there's also just like, as society, why are we okay with this? Like, why are we even talking about this? I get we're not in the 50s anymore where we had, that, I guess, nuclear household where the man went to work and the woman stayed at home. Like, we've been past that. So, like, why do we still have, why are we still functioning as if, women need to figure out what to do on our own with the kid that, we made on our own, as if we were, whatever. So I just think, like, why, it's just one of those, like, why questions that's floating in the air. Like, why is this even still a discussion?
And what does it say about us as a society that doesn't take better care of their families and their children? Like, I think that just kind of speaks volumes to me. Medicaid expansion is huge. I come from North Carolina, a state that did not expand Medicaid. And so the FQHC I worked at, we were the only place that saw pregnant women without insurance in a 3-county radius. And so it's ridiculous. And then you expect women to be able to come for prenatal care, and they're driving an hour to get there. and so we just have to do a better job. And so I think paid family leave, Medicaid expansion, and to what I think Dr. Judette mentioned earlier, the adverse childhood experience is what we're learning about kind of these fetal origins of disease. Like if we want to tackle some of these adult manifestations of chronic disease and substance use disorders, like this stuff starts way back, in this fetal stage. And so there's a lot of reasons why we should be investing in this, also just because it's the right thing to do, really, but yeah.
Judette, Liz, anything to add on this? Go ahead, Judette.
Yeah, I mean, I think the only other thing is, with the politics, all politics are local. I live in Florida, so substantial challenges in getting investment in, women and children, period. I think it's also important to have the partnerships, so that when you do have small wins, you can really expedite the gains that you make under those wins. So, Florida did not expand Medicaid, but they are extending Medicaid in the postpartum period. But we're faced with the challenge of getting the word out there as to how people should use that extension to optimize the health of mothers, where that doesn't really exist. And so that's an example where we have to partner up better so that when the politics do align and we get what we need, that we really make good use of them.
Yeah, great point. And Liz, your thoughts?
Yeah, I mean, the other piece I'll add is for researchers and scientists, as often certainly in more traditional training, have been taught, you stay in your research lane and you let the advocates do their thing, right? And not really appreciating the extent to which we do research because we want to have impact. And I think certainly one of the things that has been really powerful for us locally is work that we've been able to do, a collective impact project called the Pittsburgh Study that is focused on child and young people's thriving, right? Not just surviving, but thriving. And to imagine what it looks like when you have a commitment to healthy environments, so clean air, clean water, right, free of lead, and as well as healthy pregnancies that are with interventions that are community-led, community-driven, community co-created. And we have really set it up so that researchers and so professional scientists and citizen scientists, right, our community members are working together to really do this work. And the commitment there is that our research is transparent and that we're accountable and that we communicate. And so every time that we're collecting data, doing a survey, those results are going back to, right, community members, and it's a continuous tie of data to action. And I think that kind of dynamic is something that at a very local level, any one of us ought to be able to set up.
Well, I think with that, maybe we'll wrap up. I have been really honored to both be with this panel, to learn from this panel, and I appreciate all of your attendance and really want to thank our distinguished panel for really such an important and thought-provoking conversation. So thank you all very much. Hey, Judette, great to see you. Thanks so much for joining us.
Thank you. Great to. Well, I didn't see you, but for a brief second. But great to hear your voice.
Oh, you can't see us. We see you beautifully. We're waving at you. We are. We see your smile. We're waving.
I exfoliated. I'm just kidding.
Yes. And happy birthday to your twins.
Bye. Thank you.
Happy birthday to your twins.